Usually when you stroll down the pharmacy aisle and grab something right next to the breath mints and the chewing gum, you assume it's gentle.
Right.
Like mild. You certainly don't assume you're buying a compound that is going to permanently, irreversibly disable a piece of your own cellular machinery.
Yeah, I mean, we tend to equate over-the-counter with biologically simple. And in this case, that couldn't be further from the truth.
No, definitely not.
The pharmacology happening in your stomach when you swallow one of these pills is, it's actually incredibly aggressive.
Well, welcome to today's deep dive. Today, we are looking at a class of drugs that are so common, you almost certainly have them in your medicine cabinet right now.
Mm-hmm.
Or, someone who does. We're talking about proton pump inhibitors, or PPIs.
Yeah.
You probably know them by brand names like Prilosec or Nexium.
Yeah.
And our mission for today's deep dive is to unpack how these seemingly mundane heartburn drugs completely revolutionize the field of gastroenterology, how their irreversible mechanism makes them so uniquely effective, and why taking them long-term carries some surprising hidden risks that you really need to understand.
Right, and to really grasp what these drugs are doing, we kind of have to set the stage inside your stomach.
Okay, let's do it.
Specifically, we need to look at something called the gastric proton pump. Scientifically, it's known as the H+K ATPase.
That's a mouthful.
It is, yeah. But this pump, it essentially sits on the surface of the parietal cells that line your stomach. And you can think of it as the absolute last step of acid secretion. Like, its entire job is just to pump hydrogen ions or protons out of the cell and into the stomach.
Swapping them for potassium ions, right?
Exactly, swapping them for potassium. And this is what creates the stomach's famously brutal environment, bringing the pH down to a highly acidic, like 1 or 2.
Wow. So to understand why PPIs were such a massive breakthrough, we have to look at how doctors were trying to manage stomach acid before we could target that specific pump.
Yeah.
Because it wasn't exactly a precise science back then.
Not at all. I mean, in the early 1970s, severe ulcers were often treated as a surgical disease.
Which is wild to think about now.
Right. Surgeons would literally just cut out parts of the stomach or sever the vagus nerve to stop acid production.
Wow.
And medically, they were using anticholinergic drugs. These work by blocking a neurotransmitter called acetylcholine.
Which is what tells the stomach to make acid in the first place.
Right. But the problem is acetylcholine does 100 other things in your body.
Oh, wait.
So to get this, mild reduction in stomach acid, patients suffered these intense side effects. Dry mouth, blurry vision, a racing heart.
Urinary retention.
Yeah, exactly.
So
yeah.
They were basically carpet bombing the nervous system just to calm down the stomach.
That's exactly what it was. Meanwhile, over in Sweden, there was a pharmaceutical lab called Astra Hessel, and they were screening random compounds, just trying to find an alternative.
Just throwing things at the wall.
Pretty much. And they stumbled upon this compound called timoprazole. Now, it suppressed acid beautifully in animal models.
Okay, good start.
But the strange part was that they had absolutely no idea how it worked.
They had a key, but they didn't know what door it was unlocking.
Exactly. They were flying blind. I mean, they knew the drug worked, but they couldn't optimize it safely without understanding the actual biological target.
Right, of course.
And that puzzle wasn't solved until an American physiologist named George Sachs identified and mapped out that exact pump we just mentioned.
The H+K ATPase pump.
Yes. And once Sachs proved this pump was the terminal enzyme-like, the final gateway for all gastric acid, the Swedish chemists realized that's what their compound was hitting.
Oh, wow. So they finally had their target.
They did. So they took that original drug, rationally optimized it, and eventually created omeprazole. That hit the U.S. market in 1989 under the brand name Prilosec.
Okay, but right before Prilosec came along, the gold standard had shifted to a different class of drugs, right? The H2 receptor antagonists, like cimetidine or Tagamet.
Yeah, pioneered by Sir James Black in the 70s. And H2 blockers were a huge leap forward at the time. I mean, they largely replaced those dangerous surgeries and those awful anticholinergics.
Right.
But they had a strict biological ceiling. They only blocked one specific signal that tells the stomach to make acid.
Let me try an analogy here just to map out the difference between these two for you.
Sure, go for it.
So if stomach acid production is like a rumor spreading in a busy office, H2 blockers are like silencing one specific gossip.
Right.
Let's call him histamine. So it definitely helps quiet things down, but there are two other people in the office, gastrin and acetylcholine, who are still actively spreading the rumor. But PPIs, on the other hand, They don't even bother with the gossips at all. They just walk into the server room and shut off the entire internet router.
That captures the mechanical difference perfectly. They work downstream at the final pump itself.
Right.
And that analogy explains how the body reacts to H2 blockers over time, too. Because the other gossips are still active, the stomach eventually adapts.
It figures a way around it.
Exactly. It upregulates the other pathways to compensate for the blocked histamine. So patients often experience tachyphylaxis, which is just a pharmacological term for a rapid decrease in a drug's effectiveness.
Oh, so the body just gets used to it.
Yeah. The acid suppression from H2 blockers was only ever partial, and it faded over time. But by shutting off that final common pathway, the router, as you put it, PPIs, completely bypass the body's ability to compensate through those other signals.
Okay, but shutting off the internet router of the stomach, that requires a drug to survive a highly volatile environment.
Very volatile.
The pill has to get past the very acid it's trying to stop. So how does it physically manage to shut down the pump without just being destroyed first?
Well, it relies on this brilliant sort of Trojan horse mechanism.
Okay.
When you swallow a PPI, the chemical itself is an inactive prodrug. It's actually a weak base.
Interesting.
Yeah, so it gets absorbed in the small intestine, enters your bloodstream, and then it just circulates safely at a neutral pH. It literally does nothing to any other tissue in your body.
It's just waiting.
Exactly. It waits until it finds the one specific place that is more acidic than the main cavity of the stomach itself.
Wait, there's a place inside us that's more acidic than the stomach cavity.
Yes.
Yeah.
Inside the parietal cell, there's this tiny microscopic canal called the secretory canaliculus.
Okay.
And this is the exact site where those proton pumps are actively dumping hydrogen ions. So the pH in that microscopic space can drop below 1. When the inactive PPI diffuses from the blood into that extreme acid, the environment triggers a chemical reaction. The drug is instantly protonated, and it shapeshifts into an active compound called a sulfenamide.
So it actually uses the stomach's own extreme acid as the trigger to activate the weapon against it.
Precisely. And this new sulfenamide form is incredibly reactive. You can think of it as a biological superglue.
Okay.
It seeks out the proton pump and forms a covalent disulfide bond with it.
A covalent bond, meaning it's permanently attached.
Yeah, it acts like a weld. In pharmacology, a covalent bond often means the interaction is irreversible. The drug doesn't just temporarily sit in the receptor and block it like other drugs do.
Right.
It permanently disables that individual pump molecule. The pump is dead.
Okay, but I have to push back on the timeline here looking at the pharmacokinetic data.
Sure.
Because the half-life of a PPI in the bloodstream is only about an hour or two. So if the body clears the drug that fast, how can it possibly suppress acid all day long? And more confusingly, if it's permanently killing these pumps, why do patients always complain that it takes several days of taking the pill to actually feel relief?
Yeah, those two aspects, they seem totally contradictory, but they're driven by how the cell manages its pumps.
Okay, how so?
First, regarding the half-life. The drug is indeed completely gone from your blood in an hour, but the effect lasts for 24 to 48 hours because those specific pumps were welded shut.
Oh, I see.
Your body literally has to synthesize brand new proteins from scratch and physically install them to replace the ones the PPI destroyed.
So the drug hits and runs, basically.
Yeah.
But the structural damage to the acid machinery remains until the cell physically rebuilds.
That's exactly it. Now, as to why it takes days to reach maximum relief, PPIs can only bind to active pumps.
Right, the ones working right then.
Exactly. The ones currently secreting acid into that highly acidic canaliculus. But your stomach keeps a massive reservoir of dormant pumps hidden deeper inside the cell.
Just waiting on standby.
Right, waiting to be deployed when you eat a big meal. And the drug is completely blind to those dormant pumps because the pH around them isn't low enough to activate the prodrug.
And that's exactly why the instructions on the bottle emphasize taking it 30 to 60 minutes before breakfast.
Exactly. You want the peak concentration of the drug in your blood to perfectly collide with that massive wave of pump activation that happens when you eat your first meal of the day.
That makes so much sense.
But even with perfect timing, you only kill the fraction of pumps that activated for that specific meal.
Dormant ones are safe.
Yep. So the next day, you take the pill, you eat, and you kill the next batch. It takes about 3 to 5 days of successive daily dosing to finally wipe out the entire pool of pumps.
Which means if you take a PPI expecting it to work immediately after a spicy meal like say a Tums or a standard antacid, it won't do anything.
Nothing at all.
It's not neutralizing the acid that's already burning your esophagus.
Yeah.
It's slowly dismantling the factory that makes the acid day by day.
It's a completely different approach to the problem. And because it fundamentally dismantles the factory, doctors suddenly had a weapon against diseases that used to be, quite frankly, a guaranteed death sentence.
Yeah, let's look at that clinical shift. Because when you have a drug that powerful, it changes the entire landscape of gastroenterology.
The most dramatic example is Zollinger-Ellison syndrome.
Right.
This is a condition where a patient develops a rare tumor that secretes massive amounts of the hormone gastrin.
And gastrin is one of the signals we talked about earlier.
Yes. So that hormone floods the system, forcing the stomach to produce life-threatening amounts of acid.
Wow.
Before PPIs, the only real solution was to surgically remove the patient's entire stomach just to prevent fatal ulcers.
That's drastic.
It was, because ordinary H2 blockers, they just couldn't fight against that much gastrin. But high-dose PPIs, they shut down the final pump regardless of how much gastrin is yelling at the cell.
So they made this disease medically manageable without organ removal.
A literal lifesaver. And it changed everyday care for millions of people, too. Like a major long-term study called the Lotus trial. It tracked patients with severe GERD, gastroesophageal reflux disease, over 5 years.
Okay.
And it proved that simply taking a daily PPI was just as effective at controlling severe symptoms and preventing esophageal damage as undergoing invasive anti-reflux surgery.
Incredible. But wielding that kind of profound suppression creates a biological trap, doesn't it?
It does.
Because you're artificially turning off a natural function, you create an unintended dependency. There's a phenomenon called rebound acid hypersecretion.
Yeah, and this is a crucial mechanic for anyone taking these medications to understand. Your body naturally wants to maintain a highly acidic environment in the stomach.
It's supposed to be acidic.
Right, so when a PPI shuts that down completely, the body senses the abnormally high pH and essentially panics.
Naturally.
In response, it pumps out huge amounts of gastrin, trying desperately to force those dormant pumps to wake up and restore the acid level.
It sounds like compressing a powerful spring. You can hold it down effortlessly as long as you take the daily pill. But if you stop taking the PPI cold turkey, you remove your hand, and that massive buildup of gastrin causes the spring to just fly back up with double the force.
That plays out exactly like that in clinical settings. There was a landmark study in 2009 out of Denmark, published in Gastroenterology, that demonstrated this vividly.
What did they do?
Researchers took completely healthy volunteers, people who had never experienced heartburn or acid issues in their lives, and put them on a PPI for 8 weeks.
Okay.
When they stopped the drug, a substantial number of those completely healthy people suddenly developed new, intense reflux symptoms.
Wait, so the drug manufactured a heartburn dependency in people who didn't even have heartburn to begin with?
Yes. The compressed spring of gastrin caused their acid levels to temporarily surge well above their normal baseline the moment the drug was removed. This is why gastroenterologists strongly recommend tapering off the drug slowly, like reducing the dose or taking it every other day rather than quitting cold turkey, especially if you've been on it for months or years.
Because it is so intensely uncomfortable to stop taking them, many patients just don't. They stay on PPIs indefinitely.
And that leads us to a massive debate in modern medicine regarding long-term health risks and the current epidemic of overuse.
Yeah, let's get into the overuse.
Well, hospital audits consistently show that anywhere from 40 to 60% of inpatient PPI prescriptions have absolutely no clear medical justification.
60%.
Yeah. They're often given just as stress ulcer prophylaxis when someone is admitted to the ICU or the general ward.
Okay.
But then the patient is discharged, the prescription gets carried over into their regular chart automatically, and no one ever tells them to stop taking it.
Which means we now have millions of people who have artificially eliminated their stomach acid for years at a time, and the data shows that the body actually misses that acid.
It really does.
Let's look at the mechanical consequences of that.
So the risks tie directly back to the biological role of stomach acid. For example, the FDA issued warnings in 2010 and 2011 about increased risks of bone fractures and dangerously low magnesium levels, known as hypomagnesemia for long-term users.
Okay, but why does turning off stomach acid affect your bones and your magnesium?
Well, calcium and magnesium in your food, they don't just float around freely. They're locked tightly within complex food matrices and chemical bonds.
Right.
It takes a highly acidic bath to break those bonds and free the elemental minerals so your intestines can actually absorb them.
Oh, I see.
If you turn off the acid, a lot of that vital calcium and magnesium just passes right through your digestive tract unabsorbed. And over years, that deficit weakens the bones.
Wow. There's also the risk of C. diff infections, right?
Mhm.
Because stomach acid acts as our evolutionary moat.
Exactly. It's a natural, highly corrosive barrier.
Hmm.
It routinely kills off bacterial spores and pathogens that we swallow every day. Clostridioides difficile, or C. diff, is a bacterium that causes severe intestinal illness. If you remove the acid barrier, more of those C. diff spores survive the journey through the stomach, reach the colon, and colonize the gut.
That is terrifying. I also want to look at a very specific drug interaction involving a widely used blood thinner called Plavix, or clopidogrel.
Yes, this is a fascinating look at how drugs compete in the body. The FDA issued a warning about this back in 2009.
What happens?
It's a classic case of liver enzyme competition. When you take omeprazole, your liver uses an enzyme called CYP2C19 to clear it from your system.
Okay, pretty standard.
But the problem is, clopidogrel is a prodrug too. Your body absolutely needs that exact same CYP2C19 enzyme to convert the blood thinner into its active clot-preventing form.
Oh, no.
Yeah. So if you take both after, say, getting a heart stent, the heartburn drug hogs the enzyme. It quietly sabotages your blood thinner, leaving you at risk for a heart attack.
That's a huge interaction. So we have bone fractures, infections, liver bottlenecks. But I want to push back on one highly publicized study regarding cognitive decline.
Okay, the dementia study.
Yeah. In 2016, a major German study made headlines claiming that taking PPIs causes dementia.
Right.
But considering tens of millions of people take these drugs, is there actually a chemical pathway causing brain damage? Or is it just that older, sicker people are more likely to have chronic heartburn, take a PPI, and independently develop dementia?
That is the core issue with observational pharmacoepidemiology.
Right.
Studying drug effects in large populations over time without controlled trials is incredibly difficult. It's so hard to separate the effects of the drug from the underlying health of the people taking it.
Exactly.
When those headlines dropped, it terrified a lot of patients. But as you suspected, it was a confounding error.
I figure.
A subsequent, much larger and rigorously controlled Finnish study in 2017 looked at the exact same question and proved there was absolutely no causal link. The older population simply skewed the initial data.
Well, it's a relief to cross dementia off the list. But the other mechanical risks are very real.
Definitely.
And naturally, where there is a drug used by millions, there are massive pharmaceutical economics at play. When Prilosec's patent was expiring around 2001, the manufacturer, AstraZeneca, didn't just accept the loss of revenue.
No, they rolled out Nexium.
Right.
This is a famous business school case study on something called evergreening. Nexium is esomeprazole.
Okay, what does that mean chemically?
To understand it, you have to look at the chemistry of the original drug, omeprazole. It's a chiral molecule, meaning it comes in two microscopic shapes that are mirror images of each other, like a left hand and a right hand.
Oh, got it.
The original drug was a 50-50 mix of both hands. Nexium is quite literally just the purified, single-active left-hand isomer of the exact same molecule.
Wait, so they just isolated half of the original drug, gave it a new name, and patented it?
Yep.
By aggressively marketing this purified version as a superior successor, right as the original went generic, they extended their patent-protected revenue by billions of dollars.
Even though the actual clinical difference was what?
Marginal at best.
That is wild. But the landscape isn't just about rebranding old drugs anymore, right? There are actual new scientific rivals entering the market that work entirely differently.
Yes, there are. The new class of drugs are called PCAs, or potassium competitive acid blockers.
Okay.
A prominent one recently approved in various markets is vonoprazan. What makes PCAs fundamentally different is their mechanism. They don't require the extreme acid of the canaliculus to activate into a sulfonamide.
Okay.
And they don't form that permanent covalent bond.
So they aren't Trojan horses then. They just block the pump directly.
Exactly. They compete with potassium ions to temporarily block the pump, and they do it reversibly.
Oh, I see.
Because they don't need acid to activate, they work much faster, often on the very first dose.
And because they have a longer half-life in the blood, they provide much more consistent acid control through the night, which has always been a major blind spot for traditional PPIs.
Well, if they work faster and block acid better at night, are they just the undisputed successors?
Not necessarily. I mean, they are incredibly effective, particularly for treating stubborn infections like H. pylori,
Right.
but their potency is reigniting a serious debate in gastroenterology. If traditional PPIs already suppress acid enough to cause issues with calcium absorption and bacterial infections,
Right. What happens when you block it even more?
exactly. What happens when we use a PCAB that suppresses acid even more thoroughly? We are currently figuring out exactly how much acid suppression is truly optimal versus how much is just overkill.
That makes total sense. We've covered a massive amount of ground today. Let's recap the journey for you.
Sure.
We learned that PPIs revolutionized medicine by acting as a chemical Trojan horse, seeking out the microscopic acidic canals of the parietal cell and irreversibly destroying the stomach's final acid pump. Because they only target active pumps, you have to take them for days before they fully dismantle the acid factory.
Yeah.
And crucially, if you want to stop, you have to taper off slowly.
Yes, please do.
Otherwise, you risk unleashing a rebound spring of hyperacidity caused by pent-up gastrin.
And here's why this matters to you directly. PPIs are one of the very few irreversible enzyme inhibitors you can buy over the counter without a doctor's guidance.
Right.
If you look at the OTC label on that box, it strictly says to use it for 14 days, max 3 times a year.
Not indefinitely.
Absolutely not meant for the open-ended daily use that so many people fall into. Your body needs its acid for a reason, to break down complex nutrients and to keep pathogens at bay.
Yeah.
So if you've been taking one for years just out of habit, it's really worth having a conversation with your doctor about whether you still need it or if it's time to create a safe tapering plan.
Which brings me to a fascinating, lingering question to leave you with.
Yeah.
One that became highly relevant during the recent COVID-19 pandemic.
Oh,
We know stomach acid is our body's frontline evolutionary moat, right? It destroys swallowed pathogens, viruses, and bacteria before they can reach the vulnerable tissues of the intestines. If we artificially lower our stomach acid for years at a time, do we systematically make ourselves more vulnerable to severe gastrointestinal and respiratory infections? It's an active, ongoing scientific debate right now.
It's a profound physiological question. We evolved this harsh, dangerous, acidic environment in the center of our bodies for a critical survival reason.
Exactly. So the next time you see that little box sitting innocently next to the breath meds at the pharmacy, remember, you aren't just buying a mild antacid. You're buying a highly specific covalent assassin that will fundamentally rewire your cellular machinery. Choose wisely.